Welcome to the LDN Radio Show, brought to you by the LDN Research Trust. I'm your host, Linda Elsiegood. I have an exciting lineup of guest speakers who are LDN experts in their field. We will be discussing low-dose naltrexone and its many uses in autoimmune diseases, cancers, etc. Thank you for joining us. Today I'd like to welcome our guest, Dr. Phil Boyle, who's one of the LDN Research Trust medical advisors. Thank you for joining us today, Phil.
Thanks for having me, Linda.
So we're doing an end-of-year roundup. So what's been happening with you in your practice this last 12 months?
Well, I'm happy to say that naltrexone is still one of the key components of my intervention strategies to treat couples with infertility and recurrent miscarriage. And we had a publication this year in 2025, and we were reviewing our practice data. And normally when I'm discussing low-dose naltrexone with my patients, I explain, well, at least 50% of the people who come to my practice for fertility treatment benefit from taking low-dose naltrexone. But when I objectively reviewed our data, it was 71% of all the couples I treat, low-dose naltrexone was part of our treatment. And it's become so routine for me to recommend at this stage that it's just part of our ordinary practice. But the thing is, of those 30% or so who don't get the low-dose naltrexone, they're better off without it, I suspect, because we do try and look for a criteria and be judicious in who we think is likely to benefit from it. So we have a little brochure that we recommend, and we run it past people. Historically, it was possible to do a blood test to determine if somebody had low endorphin levels, and currently we can't do that. So what I interpret people is I make a clinical judgment and say, clinically, I suspect it's likely you have low endorphins and that you may benefit from boosting those endorphins with low-dose naltrexone. So that's how I go about it. And out of our criteria, if you have fatigue, premenstrual syndrome, low mood, anxiety, painful periods, endometriosis, personal or family history of something autoimmune, if you're fitting 2 of those criteria, we could look at that and say, I bet you'll feel better if we boost your endorphins with low-dose naltrexone. And so if I run through that questionnaire, for every 3 couples I see, 2 out of 3 fulfill those criteria, and I give them a trial of it. And very simply, I'd say it's maybe less than 5% don't like how it makes them feel. And they say, oh, don't like this, I'd like to stop it. And we go, it's good that we tried it out. It's not for you. If you don't like how you feel, I don't persist with it. Now, I know there's different strategies in the whole universe of low-dose naltrexone and the way people use it clinically, but I very much go with Bernard Bahari's original idea that if you take the low-dose naltrexone at night, you get a 3-fold increase in your endorphin levels throughout the next day, and that has this knock-on anti-inflammatory immune-modifying effect. When we boost your endorphins at night, temporarily you're going to get vivid dreams and sleep disturbance because you don't get that same deep sleep. So I let people know that, and that's okay. It's okay to be a little bit out of sorts for the best part of a week. And beyond a week, then the sleep disturbance settles and you will experience the benefits of your endorphins being boosted if that's what's right for you. So I encourage people to persist with that. And I've taken a very simple strategy, whereas I typically just do 1 week of naltrexone 3 milligrams, and then after that week we go up to 4.5 milligrams. And I find clinically for the majority of people that really works. Some I drop it down to 2 milligrams. So the range is anywhere from 2 to 4.5 milligrams, and you titrate it and you judge it clinically. But a key criteria for me is we want you to feel good in order for your health to be better and in order for your fertility to be at its best as well. And the naltrexone is a key component for that. And the majority of people, when they come back to me, because I do this on day 1 when we take their first history and they're trying to figure out, will we engage in this fertility treatment process or not. And they come back to us about 2 months later. The vast majority are enthusiastic about their experience with naltrexone. My week of premenstrual syndrome, it's just gone. My period pain is dramatically reduced. My sleep has improved. I have more energy. People that had things like inflammation and recurrent chest infections, it's less. So it's a beautiful, amazing treatment. And in those that are properly suited, and then the tiny, from my experience, about 5%, say really those side effects persisted. I didn't like it. So I don't move it along then say, well, let's try and switch it to the morning. I'd say, I think your endorphins are perpetually too high. That's why we're 2 weeks into it. Your sleep isn't good. You don't like how you feel. We're overdoing your endorphins. I don't think this is the answer in your case. So I just judge it clinically like that. And then what I've observed is, for the people who take the low-dose naltrexone and they feel really good on it, it's real important that they maintain that whenever they're pregnant. Because when I started this 20-odd years ago with low-dose naltrexone, there wasn't a lot of information about the safety of low-dose naltrexone during pregnancy. So initially, I stopped the naltrexone during pregnancy. And people that did really well on it, women in particular that I was treating, the negative symptoms would return and our pregnancy outcomes weren't so good. And we would get more miscarriages, more premature delivery and low birth weight and problems during the pregnancy, including preeclampsia. So I observed this clinically and I said, it really doesn't make sense if we have reduced systemic inflammation and immune dysfunction through endorphin stimulation with low-dose naltrexone. We're giving 1/10 of the licensed dose of 50 milligrams. We're giving 3 to 4.5 milligrams. The main clinical effect from this is your own endorphins reducing inflammation, and the naltrexone is such a low dose, and it's cleared by the next day. It's primarily endorphins that are giving us the benefit. So we looked at all of that, and also we looked at published studies about those that were on high, what we call, it's normal dose naltrexone, or we can refer to it as high dose naltrexone, but it's a 50 milligrams a day. Those that were on it for things like opioid addiction or alcohol addiction, and they were on this and they get pregnant, they took it safely during pregnancy without adverse effects. The babies were a little bit lighter, but that was probably for all of the other things that were going on in the life as well. But there's no other adverse effect to baby. And bear in mind, a 50 milligram dose has a completely different clinical effect compared to low dose naltrexone because it actually blocks opioids. But I consulted with my mentor in restorative reproductive medicine fertility treatment, Dr. Thomas Hilgers, and clinically, he was using normal dose naltrexone throughout pregnancy. And from his clinical experience that is unpublished, he said his pregnancies went better. So I explained, well, I was thinking of using real low dose. And he said, well, I'm using 100 milligrams or 50 milligrams. Not a problem for any of his patients. And he was very confident that we should be fine using the low dose. And I have to say, from my clinical experience since using low dose naltrexone, we just get better pregnancy outcomes. I treat a high risk population that should have much more incidence of low birth weight, premature delivery, preeclampsia and other complications during pregnancy because they're a high risk group. And I don't see those if I keep them on the low dose naltrexone throughout pregnancy. And so yes, you don't have 10,000 plus patients that you could point to in a carefully published scientific peer-reviewed publication, and we don't have 10,000 patients anyway, but I would say we have I've treated about 2,000 with low-dose naltrexone throughout pregnancy, and I see the parents coming back with their children trying for another baby. And they say, look at this little guy, he's great. He's a great sleeper, he's calm, he's eating well, he's reaching all of his milestones. And I think naltrexone had a part to play with that. It's really hard to objectively confirm that because I looked at a group of about 120 treated with naltrexone, 120 without naltrexone. And I've got a YouTube presentation about that. And we really didn't see any major differences except the kids in the low dose naltrexone got fewer chest infections and had a lower frequency of getting antibiotics in the first year of life. So, but I know there's more to it than that from what I've observed clinically. I just haven't been able to prove it in a peer-reviewed way. So people contact me all the time and they ask, can I give low-dose naltrexone or persist with low-dose naltrexone during pregnancy? And according to our strict scientific criteria, well, we don't have the published evidence to definitively prove that this is something that is safe, but we have significant clinical experience of good pregnancy outcomes from those who would continue during pregnancy. And the tragedy is when it's discontinued, there's this sense of, oh, well, maybe that would have happened anyway. And I say, yeah, or maybe it wouldn't have if we kept you on the naltrexone. And certainly from my clinical experience, thankfully small numbers where I experienced those losses, I'm not happy to stop the naltrexone in pregnancy. We tend to get poorer outcomes. Sorry, so I went in a bit of a tangent with that, but we just mentioned it briefly beforehand, but it's just to put that out there. I think it's an important thing for people to be aware of.
So what do you do about stopping LDN in pregnancy in case they need strong painkillers at birth?
Sure. Well, that's full term. So once you're 37 weeks and you have a chance of going into labour, and if there's a chance that you may need opioid pain relief like morphine, then you want to be off your low-dose naltrexone. Now, the thing is, if you're on it the night before and you go into labour the next day and you needed morphine, there's no problem with that. You just don't take the naltrexone again that night if you've had morphine that day, or the naltrexone is going to interact badly and you can actually be vomiting for hours on end. It's really, really unpleasant. I've had one patient that happened to, and hopefully never again. So that's one thing to look out for. But preemptively, I typically stop it at 37 weeks because you're officially term at 37 weeks, even though there's 3 weeks to go. And that's just to make sure that it's well out of your system, because Murphy's Law, you take the naltrexone that night, an hour later your waters break and you're going into labour and you find that the opioid receptors are temporarily blocked and your morphine-based pain relievers will have minimum impact. Now, most of the time, labour isn't that intense and fast and you will get time and it'll be out of your system. But it's not a headache I've encountered at all with our strategy of just stop the naltrexone at 37 weeks and make sure it's nicely out of your system when you're likely to go into labour.
And what do you do about restarting?
So for restarting it, we just judge it clinically. And if once they've recovered and they've finished their pain relief and they're breastfeeding for the majority that we would see, and pregnancy is, that delivery and recovery is complete, well, then judge how you feel clinically. But by boosting your endorphins, remember, it does help you to relax. You feel calmer, your mood is better, so this postnatal baby blues should be less. And then you reduce inflammation and mum is feeling better, and then it's good for baby. So you could say, well, if we're already less than 1/10 of the licensed dose of naltrexone and the mother is taking that, and up to 1/10 of that 1/10 can potentially get into the breast milk for baby, well, it's perfectly safe for baby, low-dose naltrexone anyway. A temporary brief block of opioid receptors for the nighttime naltrexone. If baby gets that small amount through breast milk, I've never seen a problem with it, and I'm very happy to recommend it during breastfeeding as well. I think there's more to be gained than lost, but at the same time, let women judge it clinically and say, I actually feel really good, I don't think I need it. They need to check with their partner or husband. Are you sure you are yourself? Because you don't always have insight for that. But just to be aware of it and say, really, there's no harm boosting your endorphins once you're off your pain relief and you've recovered after delivery. So I'm very much in favour of recommending it at that time.
I mean, it would be amazing for those women who suffer with postnatal depression not to have to go through that, because it can affect their relationship with the baby. And I've known a girl who just rejected her baby. She was just so depressed. Her mother had to look after the baby for the first 6 months because this woman just didn't want anything to do with her baby. And that's really sad, isn't it? So if the LDN could help minimize that, that would be amazing.
It has real potential. That combined with progesterone, you get a high dose of progesterone because there's that dramatic drop of progesterone that seems to trigger it as well. And there's work, again, in the United States where they would show if you take intramuscular progesterone and you get a really good surge of progesterone post-delivery. And for me, very much take it with the low-dose naltrexone. I think a significant number of those women won't need antidepressants and they won't hit that severe postnatal depression. But 50% of all women get the baby blues. After having baby, you just feel low, and the naltrexone can really help take the edge off that. So it doesn't have to be the full-blown severe thing. Why not boost your endorphins? I often tell people it is similar to a boost of exercise, which obviously you can't do just after delivery, but you get a surge of endorphins and everything just feels better. And the naltrexone gives those benefits that you commonly get from exercise, from that endorphin boost, obviously without the cardiovascular and other benefits, but it gives that endorphin effect, even better than exercise, because I've seen middle distance runners not do well until they take the naltrexone as well. So exercise alone isn't the whole picture, but it's that similar idea, endorphin boost, everything just feels and functions better.
And of course you have the waking up multiple times in the night, feeding, changing, which is a shock to the body, isn't it? You know?
Yeah, so it's a tough time, and I laugh because you really cannot tell it to anybody. They have to live it and experience it, and they go, okay, now we know. It's just, until you live it, you just don't really appreciate how demanding that is. So it really does take its toll, especially those first 6 weeks.
And you think this tiny little bundle of joy could create so much work.
Absolutely.
But and then they grow up and give you bigger headaches.
Yes, exactly.
Oh well, that was absolutely wonderful. Where can people find your paper, Phil, that you've had published?
So we publish it in the Journal of Restorative Reproductive Medicine. So it's a new journal that has just come out, and we're among the first, one of the first papers to be published in it. And simply, if they put in, maybe if I give you the link, that might be the best way to find it. But it's Restorative Reproductive Medicine, and our paper, Journal of Restorative Reproductive Medicine, and it's pretty easy to find in there. But I'll get the link for you and send it on so you could have it with the video if that helps.
Thank you. Yes, very much. Well, thank you very much for taking the time to speak to us today.
Yeah, you're very welcome, Linda. Always happy to talk to you. Yeah.
Any questions or comments you may have, please email me, Linda, Linda, at ldnrt.org. I look forward to hearing from you. Thank you for joining us today. We really appreciated your company. Until next time, stay safe and keep well.